TopMedTalk.
Well, hello and welcome to day 3 of Anesthesiology 2022 here in New Orleans, Louisiana. It is the annual meeting of the American Society of Anesthesiologists. TopMedTalk is in the exhibit hall at booth 2245. We've had an amazing weekend so far. Now, I'm Desiree Chappell. I'm your host, and I'm joined by my co-host, Professor Monty Mythen and Professor Saul Aronson. Gentlemen, day 3 in New Orleans.
Day 3, which is the day after night 3.
Yeah.
That's right.
We're all feeling pretty fresh, I think,
Yeah,
under the circumstances.
Yeah. It's been a wonderful weekend, catching up with a lot of friends, meeting a lot of new people, and just kind of being around, being here in the exhibit hall, the buzz of the whole thing. It's been a good weekend.
Myself and Sol did go to Frenchman Street last night.
Oh, yeah. So how did that go?
It's good. We wanted to go and check it out. Big shout out to Jeremy Sassoon, who sang that for you a few times, hasn't he?
Yeah, that is
on
on Frenchman Street.
It was a good vibe.
Hey,
there,
Jeremy.
It was a good vibe.
It was a good vibe. It was, what you come to New Orleans to do and see.
Yeah. We couldn't find our kind of jazz,
Right,
but that may
it's
not
different.
exist anymore.
It's different. It's a different kind of jazz anyway, but it's all good. Well, highlights of the meeting so far. I know we've been in some sessions. We've been really here in the exhibit booth quite a bit, but lots of wonderful comments about what's happening this year.
Yeah, I think the getting people back together is probably the biggest vibe.
Yeah.
We sort of pretended that we were back last year, but it was all masked and sparse and lots of hand gelling. We're still hand gelling, and there's a few masks around, but basically this feels normal.
Yeah.
Yeah, I agree. We're now having conversations about those days, and it's bringing back, PTSD moments and, distant memories that we refresh. But it's, I think, now something that we talk about as in the past.
Yeah, it's a bit the world PC.
Yeah,
and we'll go there again. It's inevitable, but we'll behave better next time.
Yeah, maybe.
We hope.
We will.
Yeah.
I think the countries that got hit hard in SARS-CoV-1 did well in SARS-CoV-2 because they knew what to do straight away.
Yeah,
anyway,
sure.
And we're going to hear about there's always, from all these things, there's always an upside to what you have to learn quickly in disasters. And I think we're about to hear about some of that.
Well, we are. And actually, our next guest, Dr. Michael Scott. Hello, Michael. How are you?
Good morning. Yes, I'm good. Thank you.
Well, we've actually had a lot of great conversations on TopMedTalk throughout COVID. We were able to hear a lot about the work that you were doing. So, Mike, so excited to have you on the podcast this morning. Thank you for taking the time. I know it's been a really busy meeting for you. First of all, tell us a little bit about your background, because I want to make sure everyone knows everything you've done.
In a nutshell,
not everything, but a little bit.
I trained in the UK and Australia, went through actually boarding in medicine before going to anaesthesia critical care, and then threw in a paediatric fellowship in critical care for
I didn't
good
know
measure.
that.
it's a big nutshell.
Yeah. And then
small actually.
And then really, for 15 years, I was involved with European and UK Resus Council, and also then developed the ERAS guidelines in my centre back in the UK, and helped develop that and grow that in the UK with Monty, and then came to the US in 2016, and I first went down to Virginia Commonwealth University Hospital, and now, just in time for COVID, I moved up to Penn, University of Pennsylvania in Philadelphia, to take the division chief job there in critical care, and also I head up the Tele ICU service, which we call Penn eLert, which obviously with the pandemic has been very busy.
Yeah.
Hugely successful, and a game changer, I think, in the way that technology is now being embraced and adopted across health systems.
I'm going to talk about one. Mike works with incredible teams and is an incredible let's get stuff done person. How long ago is it since your team in Guildford published the series of less than 24-hour stay for they were hemicolectomies.
They were all comers actually. They were including low anterior section with TME, and it was a consecutive series where we sent people home within 23 hours.
Ambulatory surgery centre.
And
how many readmissions?
None.
Yeah,
we published that in 2009, but we're actually doing it in 2003.
Okay, so coming up on 20 years.
20 years, yeah.
Yeah,
Is
so
that how
maybe
they still
people are
do
ready
it
for
there?
it.
Is that how they still do it there?
Yeah, nothing's changed, and the great news for me is that I've moved, and it's like 6 years on, and it's still going. There's no changes. And also down in Virginia Commonwealth, we've still got the ERAS program there. We've got flow-directed fluid therapy, opioid-sparing ERAS programs, and it's still going well there.
So people are celebrating they got their length of stay down to 4 days. They can take another 75% out of that. There's plenty to get still.
Yeah. For a different day, we're going to talk about the secret sauce on that one, Mike, because you are part of it for sure.
That's not what we're here to discuss
That
today.
is not what we're here to discuss today. So we entitled our session today, Creating High Reliability in Your Organization Using Tele ICU. You've had a lot published. Well, you've had a lot published in general this year. We're going to talk about a couple different ones that you, Monty, and I have discussed on stage actually during the meeting. But let's go ahead and dive into this concept of Tele ICU and pivoting off an article that you had just recently published in the New England Journal of Medicine. Tell us a little bit about this project and what Tele ICU actually is.
Yeah, I think it's highly topical at the moment. We saw the great adoption of not just tele-ICU, but telemedicine during COVID. And, for instance, at Penn, we were doing something like 54 consults through telemedicine before COVID. Oh, wow. And within, I think, 4 weeks, they ramped it up to over 8,000 a day.
Oh, my gosh.
The tele-ICU program was established, but we grew it right across the organisation and other hospitals like Princeton in New Jersey and Lancaster General and Chester County. And we actually had to redevelop the whole ICU system because we moved from the Philips TeleView system and built the Epic platform with Epic and put in some new cameras using something called Caregility platform. And that enabled us actually to take Tele ICU anywhere there is a Wi-Fi signal. Okay. So to give you an example of that, my Christmas present from my chief medical officer on Christmas Eve 2 years ago was the fact that we had no ICU beds left in Philadelphia, and we had a COVID outbreak in one of the ventilator sniff facilities with about 54 people ventilated. So we actually took iPads, and within 6 hours, we had established a two-way link to our respiratory therapists to support the RTs in the sniff facility with the support of a APP service, a MD service centrally going out to these centres. So I think we've had a complete game changer in technology.
Yes. So you go back a little bit to where you said anywhere that there's a Wi-Fi signal.
That's what I was going to ask too.
And you mentioned, sorry, Desiree.
Go ahead.
Expand on that bit a little bit. So we paint a picture for us.
Okay, so it might be best I just describe how our Tele-ICU platform works. Cool. So there's different models in the US. Some people have Tele-ICUs which actually directly change care on patients remotely. Okay. Yeah. Obviously, for Tele ICU, we need two-way audio and video link. You need to be able to get into access the EMR, and you need some sort of either way of calling for help, which can be just simple messenger, texting, phone, or we have a button on the wall as well for emergencies. And so if you want to prescribe stuff, then you can do it through the EMR. We have a slightly different model at Penn because we are more like the air traffic control model. And it's all about building high reliability into the health system on the grounds that no health system is perfect. And you're only as good as your weakest link. And your weakest link is often during the evenings, weekends, and nights when there's less bedside providers and the staffing ratios go up. So we have a system which is both proactive and reactive. So the reactive system is, as you'd expect, bedside provider has a problem, presses a button, and immediately gets us into the room, and we can support them with, we have 4 nurses, we have a 24/7 APP, we have nighttime MD, and we have a respiratory therapy as well. So they can then go in and support, but we're rarely actually going in, obviously, to change things. It's more about getting the right resources to the patient at the right time and accelerating that, and obviously prompting the immediate decision-making. So that's the reactive side. And we've built a whole set of best practice advisories as well in the EMR, which are very smart. And we have about 3 million algorithms running every day on all our patients, of which probably the Tele ICU service reacts to about 1,000. And as technology has improved, we managed to get down all the false alarms and build in better and better algorithms.
So Mike, that's a lot of information or data that is, transferred to information. How, I guess, operationally, how do you protocolize the pushes and filter out the less relevant data?
Yeah, so out of those millions of firings, a lot of them aren't actually firing because the patient's okay. And then you've got some advisories that come up which are warnings or just advisories. We've tried to take the noise. If you go into our Tele ICU, which is downtown in Philadelphia at Rittenhouse, there's about 8 booths, and you'll be amazed how quiet and calm it is, despite the fact there's all these alarms firing, because we took the noise and the distraction out.
Oh, my gosh.
But for governance, you have to make sure that if an alarm is firing, that our team actually can A, acknowledge it, and B, action it. So we have different types of alarms with different types of acknowledgement, and we can defer that alarm. So if it's not really important, you can just put a pause on it, defer it for some time. But we've also built in algorithmic decision-making trees. So if the hemoglobin drops and it comes up and it's 5.6, that's obviously an important one. So we have a way that we close the loop to make sure that the decision tree is there to support whoever's making that decision, and the information then goes bedside to the provider, so action is taken.
So what I'm visualizing here as you describe this, by the way, cool stuff, congratulations.
Absolutely.
What I'm visualizing is a bunch of people in an air traffic control remote environment getting inputs continuously with built-in algorithms or filters to sort of prioritize or in a hierarchical way what would prompt them to take actions. Is that a fair visual?
Yeah, so it all depends on the urgency, and the action might be they go straight in the room with a two-way audio visual and talk to the bedside provider, and might be calling another provider like an APP or a physician into the room immediately if it's urgent.
Can I go back to your... Sorry, Sol, I just want to go back to your hemoglobin of 5.6 for a second. Just tease that apart for a minute. So if it went sort of from 6.2 trickling down slowly, does it triangulate as opposed to it suddenly went down?
Yeah.
So
does it triangulate that with other variables then and say there's a hint of ST segment elevation, the heart rate's gone up, respiratory rate's increased, mixed venous saturation's gone down?
So that it gets complex, but at the moment, our BPAs or best practice advisories trigger mainly off single advisory.
So you've reached a threshold whereby
it will be a trend
is
or a threshold, and it's normally the delta that we're looking for in these algorithms.
Because as a clinician, you'd turn around and say, well, if it was 8, the last straw, and 4 hours later it's at 5.6, this is serious.
Yeah, so that will fire a red alarm, whereas if it's just trickling down, it will be an orange advisory. Or something
we can see how that can go quickly in the future. Sorry, I cut you off, Sol. I just wanted to understand how clever that got.
I could go 2 directions with this, and I think I'm going to go both directions. But I'm going to let you choose which ones you want to grab. The first is how did the COVID crisis catalyze the momentum of this entity, and how sticky is this entity now after the crisis to move forward?
So during the crisis, we had to accelerate the Tele ICU service in a very short space of time. We did that with mobile devices, mobile carts, because we have 550 fixed cameras in ICUs. So Penny's has an enormous proportion of critical care beds across
the
the health
cameras
system.
are fixed in the room. They're like CCTV
Yeah, absolutely.
Cameras.
And they're
They're fixed in the
amazing.
roof.
Yeah, and you can zoom in on a pump and you can read everything. So, or you can look at the
And I'm
patient.
guessing this is standard operating procedure hereafter.
Yeah, but it's growing all the time, obviously. But the game changer was the fact that we could link into not just fixed cameras, but even an iPad, which is how we went into a sniff facility, and
which
within
is
a few
skilled
hours,
nursing facility.
skilled nursing facility. Yeah, that's right. I think the exciting thing at the moment with the technology is that we've built the new platform within our EMR, Epic. And it's actually called Epic Hyperspace, and so we've built a parallel universe actually where we've got different dashboards and
Are you
different
the
ways
only
to
people in
display.
hyperspace at the moment, or is that a new Epic
No,
thing?
it is available,
Okay.
and of course there's other EMRs are available.
So, but do you have to have?
We're all throwing questions.
Let me ask.
One
You
at a
got to
time.
ask all of them. So do you have to? So do you have to have the Epic platform to be able to do what you're doing?
Well, we have built it with Epic within our platform because it's the EMR that we interact with.
Right.
Yes.
But the clever bit that we've done, which is unique, is that we've built dashboards so that you can go to the patients that are in trouble quickly, and with single clicks, you can then go. You can scroll through the dashboard, so you've got an overview.
Yes.
And trends, and then you can go into, say, respiratory, or you can go into cardiac.
Yes.
And it will give you everything that's going on with all the data and the trends, and also what infusions they're on, all right there in front of you. And we've actually, because there's not much room on a screen. We have these great big long screens, but even that doesn't help you always. So we've actually got a cube that spins in the middle to save real estate.
So we're at Epic back at UCL in London now. If we wanted to go to Epic and say we want hyperspace, and could we buy the pen version? It doesn't work that way. Is that right?
No, unfortunately, everyone seems to have to build their own Epic version.
Yes. Let's not get into that here because we might get ourselves into trouble.
Cry.
You can see why we're not necessarily happy about that.
Yeah.
My question is much more pragmatic. No.
Okay,
no,
you go, Saul.
Which is at the ground level of, supervising the monitor that supervises a number of patients in a number of beds. How do you decide what is the appropriate, staffing ratios?
Yeah. So we literally have a sieve as things go through. So we have 4 24/7 nurses that take all the ICU beds, and then an APP that takes another group of patients. So they have about an 80-to-1 ratio, which is high. It's higher than most Tele ICUs.
And then in the person who's in air traffic control, how many planes can they watch at a time on their radar screen?
They have about 80, and we've set up so that you've got unstable patients that you can have watching you for with all the vitals or something like that.
So when you said that there's those 4 nurses, that's all. Their only job is to monitor.
Well, they do monitor, and they do a lot of other things like check compliance with best practice, and they're all skilled ICU nurses, so that they know they have that sort of sixth sense when patients are at risk or deteriorating, and then it gets basically escalated to an APP or the MD or the RT, the respiratory therapist, as appropriate.
So the other avenue that I was going to take this sort of theme was, this is a what do you think question, but the applicability of this theme to OR management.
Yep, so we could do that. So the next stage that we have done at Penn is we have managed to build a gateway through our monitoring system and capsule so that we can send any waveform live within 3 milliseconds up to a cloud and bring it back in wherever we want. So we have some of these waveforms coming into the ICUs on the monitor on the wall. So we have
my question was more specific to the delivery of anesthesia in the OR with extenders.
Same model.
Yes, so the same model. So I was going to say, so the other thing is you can bring the waveforms actually into Epic through context that we're linking. We're the first organisation ever to do that. So then if you're giving anesthesia and you normally just have a trends chart with the anesthesia chart remotely up, we now have a way that you could bring in your actual waveforms on the monitor as well.
I think my soul might be asking, can you run 12 rooms?
Yeah, but that's what I was...
Essentially.
Yeah.
Essentially.
So
Or
yes.
20 rooms.
That's exactly right, because what you can then do is put your smart best practice
BPAs.
advisories into your platform, and you can actually then also you can adjust these BPAs, so individualize them for your patient. So I think what you're asking me is the potential to have your EMR open with all these different patients, and also then have live waveforms in. Yes, we've got that, but we would have to tweak it a bit for anesthesia. That's like our next thing to look at.
How many algorithms did you say you had for respiratory therapy? To have a whole new set for anesthesia?
It's all about situational awareness, I think, Tele ICU. The BPAs are firing, and they're always a couple of minutes behind.
Oh, yeah, you can't have that in the...
unless it's something like asystole or something.
You think humans aren't a couple of minutes behind? I mean, you reported yesterday that you had half an hour of hypotension commonly.
Yeah, that's true.
You know,
well, no, I mean, you can see
not
things.
you individually, Desiree. Those who didn't hear it,
I'm
a big
perfect.
study that was done in 2 organisations that demonstrated
but that is exactly the potential we can do now. We can build your BPAs, you can build your deltas in, so that if you've got 20 minutes of even mild hypotension, you could build an advisory in, and that can fire.
Well, I think the thing is, it's people see that they see it, they just don't do anything about it. It's
Well,
if you have a BPA firing, that's the clinical decision support.
But to continue to bridge the two applications of a common technology, and you shared with us some data about compliance and adherence to the protocols that you established in your Tele ICU respiratory therapy. I mean, you can get over that by just instilling, if you will, those protocols of ensuring compliance.
Yeah, that's right. So really, what we're building is if you think of the proactive and reactive model, enhanced recovery after surgery is just basically a bundle of macros, isn't it? In fact, all good practices, sepsis bundle is a best practice bundle. So if you can ensure that you're compliant with your best practice bundles, and then you can pick up the reactive side early and put the patient straight and fix whatever it is quicker, we know that you get a better outcome. So I think situational awareness with the waveforms is key. So I think that's why we haven't gone live with through the EMR, because although we can have the chart open and be watching what's happening in a room a long way away, you don't really know what's happening until you have the waveforms. So now we've got the connectivity to have the waveforms. I think there is the potential to start looking at how we deliver anesthesia in a different model.
Very, very interesting.
Fun stuff.
It is.
And your paper you were referring to, Mike?
I want to give credit to all my crew at the Downtown Rittenhouse and Penn Elet. Chris Ladansky, he's an intensivist that I work with, and he very kindly is working right now so that I could come to the meeting. Thanks, Chris.
Thank you, Chris.
He was first name author in a paper that we got into the New England Journal Catalyst, which was basically the history of the Tele ICU respiratory therapy service, because it was the first ever time that we had that service. And it's developed over 2 years to really be part of our whole system of building high reliability. The reactive side, it was built through COVID, and it really was reactive. And we had a huge number of people in downtown, because a lot of people who couldn't work bedside came and worked in the core. Like we had hospitalists, intensivists, medical students, everyone. At one time we had about 18 people in the core through COVID, all delivering care remotely across our health system. And the RT came out of that because a lot of the RTs couldn't work bedside because they, for health reasons, they couldn't have risk of aerosolization. So we built the reactive side, and then we built the proactive side. So the proactive side is part of our key quality indicators now. So we've built things in like just routine rounding to make sure people are on a PPI and DVT prophylaxis. We've got SBT, spontaneous breathing trial nudges, sedation hold nudges.
So these are all like a BPA, like a flag.
Yeah. And then we have safety things like to make sure if the patient is a difficult intubation, that we have a difficult extubation process, so that we don't.
So you're
just
not missing the stuff
exactly,
that starts to get missed as the units get bigger and bigger.
Absolutely. And so this is running in the background, and then we have some algorithmic things. So we have something called the ICU board, and in that algorithmic firing, like for ARDS, so we have a bundle where P2F ratio, etc., hits a threshold, and then that triggers an alarm.
I just want to get a bit of context. So for those people who haven't worked in the intensive care unit world, because it's young intensive care,
yeah,
you know, we're sort of like second generation intensivists, believe it or not. How big was the first unit that you worked on? How many beds? The first one you walked into?
My first one was about 8 beds.
Yeah,
and that was the whole hospital.
Well. That was the whole hospital, the Middlesex Hospital. 8 beds. How many beds do you have now?
Across the health system,
just stick to the one mothership.
Well, we tend to build in 12s in the US because.
And how many is the total in the hospital now?
Well, across the health system that we've got on the Tele ICU, 550 going to 650 shortly.
Yeah. So even in the footprint back in London, we're up sort of 80 compared to the 8, if you see what I mean.
Yeah, absolutely.
It's a 10x over time.
Yeah.
So we can't keep up.
Yeah.
There's a longer discussion there to have about whether we should be building all those beds. But
that's right.
Technology's got to be embraced.
Yeah, I think technology could mean that we could run far more high-level care beds rather than critical care beds. Because we have to hang on to people.
Triage better.
Merging, your experiences of the reactive management and applying them forward to the proactive. With respect to utilization of personnel, some of the things that you're doing or, suggestions should be protocolized as routine. The people who used to be in the core, looking at this remotely, are they now transplanted to be on site, bedside? Or have you figured out how to maximize the utilization of personnel so that you don't need to spread, if you will, the people to be on site, which is a lesser efficient way of utilizing manpower?
Yeah, so at the moment we haven't changed the ratio of patients to respiratory therapists bedside. But what we've aimed to do is take a lot of the routine, mundane things that they'd otherwise have to do away from them so they can concentrate on actually treating the patients. I think we've had this sort of job creep, haven't we, in healthcare?
Right.
Yeah.
That's
where
why I'm
people
asking.
do more and more. Mm-hmm. And also we have to document more and more with the EMR.
Yes.
And that's taking a huge amount of time away from people actually delivering the care. So we need to actually make our EMR smart to self-document so that we don't have to take the bedside nurse away from the patient and actually go back to the good old, nursing the patients, getting better.
Let me tell you, it's as a critical care nurse myself, it was so what created so much internal conflict in yourself when all you want to do is be at the bedside, be able to take care of somebody, do all of your assessments in a way that you're not completely rushed. But it's like you got to go back and you got to do all that charting, and you have to, deal with things that don't work, or you have to empty the trash because you don't have, your ancillary staff to help you because no
straighten the sheets and brush their teeth.
That's
makes a big difference. Yeah.
Giving a bath. That's the best time that you can take care of a patient.
Okay.
You find them. Mike.
Amazing, Mike.
Yeah, it really is. I want 2 things. One, adoption by the teams, because we talk a lot about technology here and how it takes so long to adopt new technologies. Obviously, during COVID, there was a need, and I could see rapid adoption. As you go on, constant I'm sure you're getting constant feedback. What is the feedback, though, from the teams that are using this, especially with nudges? You hear a lot of people in the Epic space, don't add another BPA, don't add another warning or a flag, because you get... you get this creep of people just ignoring everything. It's like alarms.
Yeah, I think the system we run is the air traffic control tower. So we are advising and going into help and trying to take work away from people. Yeah. Different people do perceive that in different ways. So we do have sometimes pushback from bedside providers who think that we're sort of an eye in the sky and looking over what they're doing. That isn't our role at all. And it's all about education and making them realise that we're working with them. And in fact, when we have watch lists, so if you've got one APP admitting on the medical service and they've got 8 sick patients, they can literally say, can you just look after the DKA and do what you think needed while I admit these two? Diabetic ketoacidosis or something like that. So once they learn how to use us, I think that we're very welcome. Yeah. So it's important about the education and the message that gets out there, that we're not just watching what they're doing.
Yeah.
It's more centering care on the patient, and especially at the evenings and weekends, which is where we have the most value for the reactive side.
The aviation industry has evolved to not have the relationship between ground traffic control and the pilot be competitive or one of paranoia, but rather a necessity to function at the highest level. And that sort of emotional reaction is one that we're going to have to evolve to as well.
Yeah.
I think what is very interesting is that when you do sit in the chair and you've got the eye in the sky, you see patients very differently because you're seeing the trends, and it becomes very obvious that the patient in bed 2 is deteriorating.
Right. Yes.
Whereas when you're on the ICU, as I am as well, bedside, and you're walking up and down, you don't always get that information to you.
Do you think we get to a point, I mean, they've done it in radiology, so the idea of reporting during your daytime for X-ray films, which certainly happened in the UK some 15 years ago or so. During the daytime, we did Australia, and at night Australia did ours, if you see what I mean. So they reported the films when they needed reporting, so you didn't have that fatigue factor. Do you think those people will start to exploit even the time difference in the USA would make staying up at night a bit easier? Is that a step too far? Or?
No, I think it's already done because there's an Australian group that do Tele ICU for other parts of the world.
Yes,
because they're
in the US yet.
I'm not sure, to be honest.
Because it kind of makes sense. Everyone works in their daytime.
Yeah.
You've got to have a lot of people to run in the room, obviously, at night, but the eye's on. You can do it. Yeah, great.
Well, Mike, the last thing I wanted to say, I made a couple notes here, was that you said that this technology could be used for higher levels of care, but it's almost like it's a higher level of monitoring, not of care, because it's not necessarily that you need the care, it's that you need the monitoring. And, there's a lot of wearables and different types of new technology and things out there, all of that integrating, or do you have any new monitoring technology that you've integrated now into this?
Yeah, so it's all about the right monitoring for the right patient at the right time.
Great.
And we go for surgery, we're going from the OR, then stepping down into the PACU, and then normally the floor. Mm-hmm. I think the biggest challenge we have in medicine at the moment is we have this huge gulf between the PACU and the floor, because you're going from continuous
even in your
blood pressure
shop
monitoring.
Now, have you closed that gap yet?
That's what we are trying to work on in the high-level care areas. So we're trying to go to continuous non-invasive blood pressure monitoring, because then you can actually fire BPAs off it. Because if you've only got a 15-minute blood pressure going off, or even a 4-hourly blood pressure, you can miss a lot.
But you don't need a 2-to-1 nursing ratio on that.
Well, the idea is now you've got the wireless technology, all the patients. So you could just literally have 4 patients in each of our hospitals who are deemed high level enough to need continuous blood pressure monitoring, and hook them all up on a watch list and have them centrally monitored downtown by the Tele ICU.
Mm-hmm. Yeah, it's possibilities are endless for sure. Well, Mike, I wanted to make sure we capture that again. So tell us again the articles that you've had come out and where we can find those.
Yeah, so it's about the respiratory therapy service. It's in the New England Journal Catalyst in June. And as I say, thanks to Chris Ladansky and Huffenberger.
Is Catalyst open access, Mike?
It is, I think. Yeah. And of course, Bill Hansen, my CMIO as well, I have to mention.
Yeah, absolutely.
And you had some other articles out recently. We're looking at the acute kidney injury data yesterday with the...
Yeah, that's from my previous health system, VCU.
Big financial opportunities to reduce the incidence of post-operative acute kidney injury.
Yeah, so basically we did... we looked at all surgical patients, non-cardiac, over the year before COVID, and they're basically the 1-year mortality. 4 stages of AKI.
Something patients.
Yeah, about 6,800. Yeah. And we looked at the costs as well. We did a modelling for the costs. And the surprise, no surprises with stage 3 AKI is bad news generally, and stage 2 pretty bad news. But what surprised us was that the odds ratio, if you had stage 1 AKI, is that your mortality at 1 year is 1.9.
So that's what we used to call the creatinine bump. In other words,
so we ignore these. Yeah, absolutely. So really, there is no such thing as a mild AKI. It all seems to have a downstream effect, and your mortality went up 7%. So again, it's all about which group do you want to be in, and the cost implications even for mild AKI were about $4,500.
And some people would say, well, that's just a marker of the fact that they were less well, but you did manage to change the rate of AKI as well, didn't you? So you intervened and you reduced it. So
we did the
2-point harm.
Yeah, 2-point flow-directed therapy optimization after induction of anesthesia before surgery, and then at the end of surgery when the patient's flat and there's no gas in the abdomen if it's laparoscopic. And that had a profound effect on AKI. So we got another paper coming out, and in the highest risk group at the time, which was our colorectal group, we brought down the rate from about 15.5 down to about 7% in that group. But in general, all the AKIs were going down. And it was interesting, we stopped some really severe AKIs, and we got rid of a lot of stage 1 AKIs. But it does seem there's some patients who have poor renal reserve that always are going to have some badness.
Where's that paper?
That one is in the Journal of Clinical Anesthesia, and that is literally coming out. Yeah. It's out online, and it's great. Hard copy in November. So, hot.
Mike, I can't even tell you. Thank you so much for chatting with us again. It's always a pleasure to hear what you're up to and what you've done.
It's been wonderful, yeah. Thank you.
Yeah, appreciate it. Well, we will definitely put all the links in our show notes whenever the pod comes back out. So we will do that. And thank you for listening to TopMedTalk and watching the live stream if you're watching. If you like what you have seen or heard and you want to listen to it again or share that with friends, you can find it at TopMedTalk.com. It's TopMedTalk.com. We wanted to take this opportunity to thank our sponsors and our supporters for us to be here. TopMedTalk is free, open access to the world. We're listened to in over 100 countries, and that is not possible without that support. The American Society of Anesthesiologists have provided us this amazing booth here in the exhibit hall. It's prime real estate for sure, and we wanted to thank them. We also have platinum sponsors.
We do. Edwards Life Sciences and Medtronic in particular. We've got lots of other great sponsors, but those are our two platinums, and Edwards in particular stuck through us the whole way through.
They got
us going.
They have. We started on the Edwards booth in 2017. So,
and we're greatly indebted to all our sponsors, because without them, we wouldn't be able to fulfill our mission, which is to just give these podcasts and data and educational venues free to everyone in the world who wishes to see them.
Yeah,
so
absolutely.
Thank you again.
Thank you. Again, thanks for listening to TopMedTalk. We'll be back actually talking to the global scholars, which we learned about this meeting from Dr. Elizabeth Drum and the Global Outreach Committee. So please do stick around for that. Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.